delighted to share the next hour with everybody on this topic. I would like to thank the Eyes on Eye Care organisers for inviting me, and of course I very much appreciate you guys tuning in and joining me as well. My name is Jill Woods. I am the Head of Clinical Research at CORE, and CORE is a research unit that's located at the School of Optometry in Waterloo in Canada. I've been there for 17 years, and before that I spent probably the same amount of time in private practice, working like you guys do, seeing patients and chatting with them. I worked in my own practice, and when I moved I was managing a practice. So I like to think I can bring two hats to this presentation today. I've got my clinician hat and practice hat, and I've also got the research hat that I've been working in for the last little while. So two different perspectives to share with you. As I said, I work in a research unit. We're an independent research unit. We are not affiliated with any company or product. We work with anybody who wants to do research, and these are my disclosures of the companies and granting organizations. So let's get into the topic. Why are we interested in multifocal contact lenses? Well, we care about them because about a quarter of our population are presbyopic. So a quarter of our patient pool is presbyopic, and we need to be offering those good service and options for correcting their presbyopia. And the population is only getting older, we're told. 60 is the new 40. Our presbyopic patients are healthier than ever. They are more active, they're more connected, they have disposable income, and quite frankly, they're not prepared to put up with the compromise that spectacles can offer them. They want something different, and they want options. So we're going to spend the first section of tonight talking around various myths that still exist, and there's still a bit of a dogma around multifocal contact lens fitting. Now, I didn't invent the idea of contact lens myths. Nathan Ephron 30 years ago published a paper and explained that there are still 8 contact lens myths that need to be busted. My colleague Karen Walsh just last year published a paper on 10 contact lens myths that need to be busted out. They are not true. And actually, of those, we're covering a lot of them tonight. Not all of them, but most of them, and as they reflect to our multifocal population. So I'm going to take 2 for 1 on the first slide and deal with 2 of the myths. Number 1 is the fact that fitting multifocal contact lenses is complicated. And number 2 is that the fitting takes up a lot of time. Now let's explore these myths and where do they come from? Well, why are they still complicated? They've been around a long time. First ones in the 30s, the first simultaneous multifocal patent by John DeCarle in 57. After that, we had various optical options available to us through the 80s and 90s. They kept coming. And I was practicing then. I remember them being quite excited. So why is it that we're 40 years on, and when we survey practitioners, they're still saying that I don't really understand multifocals, I'm not successful with them, takes up a lot of my chair time. So we need to overcome this. And really the evidence these days doesn't support these. In clinical trials, the reports are that if you're fitting someone with multifocals, it takes maybe 1.5 lenses to fit that eye. That's not greatly different to fitting a single vision lens optimally, which seems to come up at around 1.3. Now, we can't fit 0.3 of a lens, I know. So we're talking somewhere between 2 and 3 contact lenses to fit somebody in a multifocal lens. That doesn't seem like it's an awful lot of chair time or complicated. Also, more recently, we've had reports that 8 out of 10 patients can be fit with the first pair of multifocals on eye. Now, first pair success is great. We know that that translates into far reduced chair time, and it makes life a lot less complicated for us as practitioners, and the business can keep flowing. So if you're not getting these success rates in your practice, we need to find out why. And you may be thinking, what what's so special about clinical trials? Why can't I get that? And again, I've had feet in both camps here, and I can tell you what's different about clinical trials is that there's a much more rigorous control of the procedure. Whenever we're doing a clinical trial, there's no clinical judgment. There's no, well, this worked last week, so I'm going to try it this week. Everything is step by step. We start off with a very careful refraction, and then we always follow the fit guide to the letter. So if we can translate this into practice and get that success in practice, that would be fabulous. And really the key point is use the fitting guide, the correct fit guide for the brand that you're using. And there are different brands within different manufacturers, and they will all have a different fit guide. So these guides are online. That might work in your environment, or you can have a hard copy. But really looking at it and following step by step is going to be absolutely key to making that work for you and reduce that chair time. The guides will assist you selecting the first lens to put on eye. They'll help you optimize the powers and help you troubleshoot complaints, whether that's in the fitting process or at one of the subsequent follow-up visits. So fit guide, and fit guide would be my advice to making everything much less complicated. If we move to another myth, and I'm going to steal another 2-for-1 here, is that I do hear practitioners say that multifocal contact lenses, yeah, even when I get it, they're not successful. Patients they don't work, particularly perhaps with emmetropes and neophytes, they just don't work that well. So yes, that's based somewhat in fact. Practitioners are still reporting that the success rates are too low. And we certainly would love to improve and reduce dropout across the whole contact lens wear industry. The retention rates from neophytes, for example, is just 9 in 10, but that's lower when we look at the presbyopic group. So if we're looking at a 60-year-old age group, then retention rate is 64%. Let's look at that the other side. That means 2 out of every 3 is staying in contact lenses. So it's not all doom and gloom for us. And the reasons that people are discontinuing in that presbyopic group are dryness, discomfort, and poor vision. And we'll come to those towards the end of the presentation in addressing them. But, they're not things that are insurmountable for us. Evidence tells us that there's certainly under-prescribing of contact lenses in this age group, and there may be a reluctance amongst the industry as a whole to address multifocals with our patients. 50% of contact lens wearers seem to drop out of contact lens wear altogether when they become presbyopic. And those that stay in, only half of them are fit with a multifocal contact lens. So 40% of those that stay in continue to wear a single vision lens. Now that might drive dropout altogether, because wearing a single vision and readers over the top on and off is not particularly lifestyle enhancing either. So I wanted to give you some practical tips to sort of improve your success rate in practice. Some of these you may be doing already, some may deserve a second look at and another careful thought. But really, I've come across these from my own experience fitting multifocals and from those I hear with my colleagues within the research field. But also we do some work with practitioners, and knowing their response and how they work with the contact lens fitting process has also helped me to sort of reinforce these steps as being quite important as we go through. So one of the big ones is you need to start with a current refraction. Don't work off a script that's brought to you. Don't even work off a 6-month-old script that you may have done. Recheck and re-refract them. And when you're doing that, push the plus a little bit. If somebody's hovering between 2 powers, land on the more plus side or the lower minus, and do a binocular balance to make sure you've got a balanced prescription to start with. And I know some practitioners have reported to me that, well, if I'm fitting a multifocal lens, I'm going to push the plus a bit so to make sure they got plenty. Don't do that. There's no need. The multifocal lens designs will cover that base for you. Two other things that people sometimes get tripped up on is don't forget to do a vertex correction for the powers that are over around 4, particularly with your myopes, so you'll be over minusing them. And when you are converting to a spherical equivalent, err again on that plus side. So just ignore the minus 0.25 and err on the plus. We've already covered the fit guide. It's still important. Keep that at your right hand. If your particular design that you're using needs a dominant eye, theories now have shifted. There are different ways of assessing dominance, but most people now agree to use the blur suppression method. So hold a plus 050, a plus 150 over each eye in turn. Whichever eye it lands on that has the least interference with vision, that eye that it's covering is your non-dominant. So if you were using the sight dominance before, the hole in the card, maybe flip around and try this blur suppression method and see how that works for you. So if we take all this knowledge into practice, then, let's think about how we can improve success. And the first step in that, I think, is we need to redefine what success is. To my mind, somebody is a successful lens wearer if they're happy wearing the lenses when they want to. Doesn't have to be full time. So I don't wear the same shoes every day. I wear shoes for the task. I don't wear the same shoes to work that I wear to the gym. So contact lenses, spectacles, let people choose the vision correction to meet the task that they're doing. That's what modern optometry and contact lens practice is moving towards. We've got lots of options. We've got wide ranges of materials and replacement frequencies in order to do that. Maximize your success with a careful refraction and keeping that fit guide to hand. And the more you do it, the easier it'll get. You'll become more familiar with the fit guide steps. You'll become more familiar with the design. So again, practice can certainly make perfect. And do we need to think any differently to keep those neophytes successful and those emmetropes? I remember somebody saying to me that, oh, emmetropes are the worst. They just don't do well with multifocal contact lenses at all. And I must admit, that's not been my experience. I find emmetropes are really keen to stay out of spectacles, especially in this age that's a little bit sensitive. 40s, everything else starts to fall apart. Nobody wants to suddenly start wearing glasses. So I find that that's a fairly easy transfer across. And I was involved in a study where we fit emmetropes, and 9 out of 10 of them wanted to stay with those contact lenses. They may not have wanted full time, but they certainly saw that they had a place in their life. So that would be a high success rate. One thing with neophytes who've never worn before, it doesn't matter their age, but it's applicable just as well to presbyopes, is that handling can be a reason for discontinuing. So if you can manage that handling issue and check in with them, make sure it's not a problem, maybe a phone call, perhaps have one of your staff act as a bit of a buddy if somebody's struggling a little bit and check in with them, offer a Zoom call, Teams call. It's very easy these days. Everybody's geared up for it, and you can just watch how their insertion removal techniques are. One thing about neophytes, they've never worn lenses before. This population are older, they're more successful, they're quite confident. Please treat them a little bit like you might treat a teenager. This population still don't know anything about contact lenses. So just as you would with a teenager, you tell them once, you tell them twice, and you ask them to tell you what you just told them. Because the last thing you want is somebody to develop bad habits and be non-compliant with the wearing or the caring of their contact lenses. So just keep that in your back pocket, that just check in with them on compliance and make sure they're doing everything right. You just can't re-educate any wearers too much in this situation. Let's move on to another myth, the myth that monovision is better than multifocals. Now, this myth might come from the fact that it's very easy to understand how single vision lenses work, and it's very easy for us to sort of tweak the prescription to make the distance better or the near better. So it's comforting as a practitioner to live in this space. And a lot of practitioners report that patients actually prefer monovision and that they don't seem to have a problem with stereopsis, so does that really matter either? And our recent multifocal designs do tend to lean a little bit into that multifocal space because they do ask you to pick a dominant eye and do different tweaks to the prescription depending on which eye is dominant and which isn't. So there's a little bit of a reinforcement perhaps happening here. But the evidence around monovision and multifocal doesn't support that monovision is better. It works for some, but the evidence actually favors multifocals. So multifocal lenses do provide better stereopsis, and they also provide a wider range of clear vision. They cover close vision and the intermediate range as well. And there have been a number of studies fitting monovision and multifocals on looking at the outcome and the patient preferences. And one of my colleagues, Ping Situ, she refitted successful monovision patients. And after the end of a month experience in multifocal, almost 70% of them actually preferred the multifocal and said that they would like to switch over. Other studies have also come up with the fact that more people prefer a multifocal. I was involved in a study shown on the screen here with very early symptomatic presbyopes. They were contact lens wearers and they were just starting to be symptomatic. Their NIRAD was 1, just under 1. Now, the monovision and the multifocal gave similar stereopsis. The monovision gave better acuities in the exam room, so the VA was better with monovision. We fit and dispensed the multifocals and the monovision and asked them to do various tasks and note how their visual performance was. And the multifocal performed better for real world and out and about life, performed better for driving tasks, watching TV, socializing, shopping, looking at signs in a supermarket, all those things. And overall, they preferred the multifocal to the monovision. So that's kind of interesting that what I measured in the consulting room was better with one, but when the patients came back, they preferred the other. So this is sort of reinforcing that a real world experience in these contact lenses is not necessarily going to match what you measure in the exam room. So it's always worth providing that real world trial for your patients. It could be just a 15-minute walk outside or across to the shop next door or down the road, or it could be a full, 1 week, 2 week trial of wearing them, excuse me. But that real world experience really will allow that patient to explore and understand whether that lens works for them in their lifestyle. You should consider the impact on binocularity as well. Fitting a non-dominant eye for near vision, which is how monovision typically works, may not work so well for somebody who's got a very demanding job doing a lot of close work. One eye is always suppressed in monovision, so there's always that element of compromise. Not that multifocals are without compromise, it's different. And as the ad increases in monovision, the intermediate vision becomes more and more compromised and almost lost. Computer vision becomes problematic. And there's an increased awareness of the eyes not working together. So it's been reported that the performance of monovision kind of maxes out at around 150. And that's certainly been my experience. I don't know how you've found it in your practice. So moving on to our next myth, do patients with 1 diopter of astigmatism or less do fine with spherical contact lenses. Do we need to worry? Now, this is pertinent, particularly these days, because it's not been too many years that we've had multifocal toric contact lenses available to us. This was very much an underserved population. So just thinking about why we don't correct that low astigmatism in general, is this based on historical issues that we know poor rotational stability with lenses? The lenses have been thicker, it's been harder to fit, they're more expensive. Some people still report to me that they think they can mask low astigmatism with a thicker lens. We'll come to that at the end as well. So what does evidence tell us here? Well, it's quite surprising that the prevalence of astigmatism in the population is quite high. 1 in 3 people have astigmatism of at least 3/4 in both eyes. Now, that's the general population, but astigmatics get presbyopic as well. So we do need to think about them as they're moving into that presbyopic phase of their life. And not correcting the astigmatism fully is certainly impactful on vision, whether it's reading speed, stereo acuity, discomfort, eye strain, headaches. And we know that astigmats are overrepresented in the people that drop out of contact lenses and the people that complain of poor vision in their contact lenses. So it absolutely is ripe for getting definite benefits of fitting these lower astigmats with a fully correcting lens. Now, I do have a slide here I borrowed from my colleague Lyndon Jones, and he likes to share this whenever he can. And as I said, some people do feel that we can mask astigmatism with a lens. We can choose a thick lens, we can choose a stiff lens, but I just want to show you now topography maps that show that this is not the case. This is a corneal cell, about 1 diopter. We put a thick hydrogel lens on. That overall cell is still 1 diopter. If we put a nice stiff silicon hydrogel lens on, that cell is still 1 diopter. We're not getting any correction with soft lenses on top. So that's a myth within our myth section here. You cannot cover up still. So when we're in practice, it's worth thinking about these low astigmats. It's worth thinking, can we just upgrade them and give them those visual benefits that they deserve? We know with general population that you get a measurable upkick in their visual acuity, and they notice it, they report it, and given the choice, they would prefer the vision with a toric lens to a single vision. And we have modern soft toric multifocals available to us now, and they are reliable. These designs work well. The toric component is fit the same as any other toric. It's nothing that you're not familiar with. And nobody's going to have a full fit set of multifocal torics in their practice. So feel free to check that fit with a single vision lens on eye, and then transfer your rotational needs to the multifocal order. And in terms of fitting success, we've had a recent report out of North America and Europe that you can still get very good successful fits with fairly quickly with a multifocal toric. 98% was successfully fit with just 2 pairs of lenses, so or less. So still not too much chair time, not too much complexity. So I've covered 6 of the sort of common myths that are still creating a bit of a dogma around fitting multifocal lenses. Hopefully what I've shared with you here reinforces the fact that we should be ditching these myths. They don't deserve to be existing now with the modern contact lenses that we have today. And, you know, not true. Let's start with a clean slate. So with that in mind, I'm going to move into the second part and cover some common questions and tips about multifocal contact lens fitting that I hope you'll be able to take on and expand on in your practice to allow you to enjoy fitting multifocal contact lenses. So our first question here is, will my presbyopic contact lens wearers get improved comfort with a silicone hydrogel lens? What does our evidence tell us? Well, we can look at the journals and find that there's been much review into this question, and the very short answer is, it doesn't make any difference. You can put as much oxygen to that cornea as you like with the most breathable, highest breathable silicone hydrogel materials. It really doesn't impact the comfort of those contact lenses. So that's interesting. But then a lot of people, when they start to think about hydrogel or silicone hydrogel, start to think about lens deposition. So what about deposition and its impact on comfort? Now, the thing about lens deposits is that by far the majority of lens deposition is not visible to us on a slit lamp. We can't see it. But there might be a ton on the lens. We can look at a dirty lens like this and look at what seems like a clean lens. And actually, the clean looking lens has the more deposits completely. And it's not the amount of protein that's on a lens that's related to comfort. It's the amount of denatured protein that seems to be linked and is detrimental to comfort. But we also can't look at a lens on a slit lamp and decide if the deposition and the protein is denatured. So visible deposits is tough, and the best thing to do about a lens that anyone that deposits heavily is to change their replacement frequency. It really was only an issue when we had lenses that we were trying to keep lasting for up to a year. Reducing to frequent replacement lenses, monthly, 2-weekly, weekly, daily disposable, is all going to have a benefit to that. That's the only real way of making a significant change in the way that patient deposits on their lens. But what about the physiology between wearing a hydrogel lens and a silicone hydrogel lens? So there's been some extensive review into this question as well. And one of the extensive reviews came up with the fact that there's really people that have worn hydrogel lenses for many, many years still show no hypoxic compromise whatsoever. Another study here that I've shared with you is where reusable silicone hydrogel multifocal wearers have been refit with a hydrogel daily disposable multifocal. And there's been no difference in corneal swelling, corneal physiology, limbal redness, corneal staining, no difference at all. Now, these studies, of course, relate to daily wear and of a moderate prescription. If you've got a very high prescription, or you've got somebody who wants to sleep in their lenses, then silicone hydrogel is going to be a more favorable option for you, of course. But in terms of hydrogel, there's really no problem with wearing hydrogels in terms of any increase in infective corneal infection risk. There's no change in comfort. There's perhaps a slightly lower risk of mechanical complications. There's definitely been a lower risk of inflammatory corneal infiltrates in the reusable lenses with hydrogels. And of course, hydrogels are generally a lower cost as well, so there's some advantage there. So when we come to choosing a material for the patient in the chair, it's worth remembering that increased oxygen does not mean better comfort. And there's no evidence to show that fitting a material that deposits less has an impact on improving comfort, particularly in a frequent replacement modality. And for low to moderate prescriptions in daily wear, hydrogel material has no impact on corneal physiology. So it leaves you free to choose the lens that you think is going to work best for the patient in the chair. Choose the optical design that's going to work best for their vision and their prescription. We've got lots of choice in the materials in frequent replacement as well as in daily disposables. And this chart here shows the new fits, the most recent results from the International Fitting Survey. And you'll see that hydrogels still has a fairly decent stake in the market. So practitioners around the world are certainly not abandoning the hydrogel lenses. Our next question here is how to prevent dropout in my presbyopic patients. Now, of course, we mentioned this earlier. Dropout certainly is a concern for us in contact lens industry across the board, no matter what age. Dropout does range from, got figures here, 12 to 27%. And new wearers of any age tend to drop out 1 in 5. So you'll retain 4 for every 5 that you fit. That's disappointingly high dropout rate, really, for new wearers, but it's been repeated in various studies. Now, the dropout is higher still when we come to presbyopic neophytes in that first year. So at ages of 60 plus, 1 in 3 will likely drop out of lens wear. So the established wearers and the new wearers have slightly different percentages. But the important thing here moving forward for us as practitioners is knowing the reasons and managing those reasons. Dryness and discomfort are typically our number 1 and 2 for dropout reasons. With presbyopes, we add in poor vision as well. So we need to keep a check on comfort and on vision. And for a new wearer, handling comes up quite high. I mentioned that earlier. We need to manage the handling. So in practice, it's not all about discomfort. For a new wearer, keep checking in about the handling issues and try and make them super confident. Tiny little tweaks in technique can make a big difference. To manage vision, need to just keep checking in on these people, repeat a careful refraction at your aftercare, make sure there's no prescription change. If there's an increase in ad or a change in prescription, go back to that fit guide. Start from selecting that first trial lens again and you follow that fit guide through. You won't be able to fix everything for everybody. There are challenging tasks. And in this day and age, we've got daily disposable lenses. It does make it easier for you to offer somebody a pair of distance contact lenses for those challenging times. Night driving, going to the theater. There's no problem with saying to somebody, yep, I hear your problem. Here's a fix for you. Why don't you have a box of these, and then when you go into the theater, you don't need to wear your glasses anymore. You can still wear your contact lenses. You just wear the different contact lenses. So again, matching the needs and the expectations using all the tools in your toolkit. But comfort is the big one. And that certainly needs a little bit of thought, and let's talk through that. So comfort can be related to the contact lens, and it can be driven by a number of factors here. It can be the lens design itself, the varying thickness, can be due to the surface chemistry or the bulk chemistry of the material. We've got lenses with complex chemistry profiles now. Again, the replacement frequency can be the problem. If somebody is a depositor, and as I said, you can't always tell by looking at the lens, it'd be nice if we could, but changing that replacement. But remember what I said earlier, silicone hydrogel has not been shown to be a more comfortable lens than a hydrogel. And the reverse is also true. So other properties that do affect comfort you can look for. You can check that the lens is fitting well. Is it moving too much? Is it not moving enough? Is it decentering? That's certainly something that you can deal with and address by changing the lens. Think about that replacement frequency. Maybe consider using a material that's reported to have higher wettability on eye or a lower surface friction. Those changes may make that lens more comfortable. but you can't always change the lens. Certain prescriptions are not available across the board. And if you need a certain multifocal design, you can't always find that in a different lens material or different modality. It's been shown quite clearly that changing the care solution can actually have a significant impact on the comfort of the lenses. So that's one to try. And we're actually finding more and more evidence now to show that how significant the ocular surface, and in particular the lid margins, can be in their impact on the comfort of the contact lenses. So when we come to trying to manage that patient in practice with that poor comfort, then you can get big improvements by changing the lens and the lens care, but there are other things you can do as well. And I would suggest that you are always proactive in looking at the eyelid, the lid margin, and the checking for dryness on the eye in total. The dryness can be managed and helped a little bit even by putting a drop on 50 minutes before lens application. I know some of my colleagues that work in practice, they recommend putting a thicker gel in at night so that that ocular surface is actually primed better the next morning to receive that contact lens. Again, you may think it doesn't have an effect overnight, but my colleagues tell me that it can work and it can be impactful. But especially impactful will be addressing anything around the eyelids. So check that lid margin, look at the meibomian glands. Are they expressing? What kind of quality is the meibum they're expressing? Is it impacting the tear film stability? And, you're perfectly capable of managing anything you find there and creating improvements. Ask your patients proactively about contact lens comfort. Some patients won't tell you. They think what they're experiencing is normal for contact lenses. They might even be afraid if they complain, you'll take them away. So open-ended questions, safe environment, let them give you the information so that you can help them. And you can ask questions like, do you have to remove them before you want to every day? Is there a gap between your comfortable time, how many hours are you struggling before you take them out at the end of the day? Things like that will help you. Our last section here is, I could talk about this one for a long time, but how can I grow my multifocal contact lens business? And really, the answer would be start talking to patients and keep talking to patients. As I said before, half of the existing contact lens wearers drop out of lens wear when they become presbyopic. Surprisingly few people know that multifocal contact lenses even exist. They can't ask for something that they don't know about. And we know that patients are afraid to ask. They assume things will be recommended by their eye care practitioner, but sadly, there's often a gap in that communication. Emmetropes will be very happy to avoid spectacle wear. Don't think of them as your problem child. They will actually take contact lenses and multifocal contact lenses and really enjoy wearing them, but they need to know about them, know that they exist. And when you're speaking about multifocals, talk about the benefits that they bring. Don't talk about the problems. I know I fall into this trap. I say, well, they're okay. They'll solve most of your vision problems, and they'll probably do that most of the time. How negative does that sound? So let's flip it. Let's talk about the benefits. And there's literature out there to show that presbyopic patients experience the same wonderful things about contact lens wear as our younger patients. Better quality of life, better vision. I feel more attractive. I feel more confident. Who doesn't want that when they're 55? Everybody. Introduce multifocals as problem solvers as well. As I said, our presbyopes, they're more active, they're more engaged, they're fitter, healthier than they've ever been. It's very difficult to do a downward dog in a pair of spectacles. They fall off. It's also very uncomfortable doing your salsa spin in your progressive spectacles. So there will be hobbies that you've pulled from your patients that will lean themselves towards a multifocal fitting. And the last point, again, I'm circling back on this one, redefine what a successful fit is. Your patient does not have to wear them all the time. Dual wearers love glasses and contact lenses. They don't have to be mutually exclusive. Other ways you can improve contact lens, your multifocal market, is to make them more normal in your practice by having posters and literature, mailings, to just present it as just another option. You can source materials to help you with this from the various organizations. BCLA will be launching their Clear Presbyopia report at the end of this year. I've got a shameless plug on screen for CORE's Contact Lens Update. This is our 2-monthly magazine, and in December we had an issue dedicated to multifocals. It's got little bite-sized pieces about a very topical topic every 2 months. Train yourself, train your staff on all of the various options here. The evidence tells us that our spectacle wearers want to know what's available for them. We've got very strong evidence that proactive recommendation really works. You'll see a massive change in contact lens trials once you start recommending them, and that will translate into contact lens purchases. There's also plenty of publications around using contact lenses as a spectacle dispensing aid. You put contact lenses on, you'll see an increase in the value of the spectacles, as well as more contact lens patients being converted. So again, double whammy, being proactive. And proactive all the way is the way to improve your multifocal wear. Inform them, use contact lenses as a frame selection, use them in walkout trials, whether it's just a 15-minute or a couple of weeks. And I know some colleagues that host contact lens evenings. They do them for younger groups, but you can do them for multifocal wear as well. People get booked in, you pre-order the trial lenses, put them on, people mill around and share their experiences. It can be a super fun way of generating some excitement. But just remember, you do miss all the shots you don't take. So give that next presbyope a shot that sits in your chair. You only need one happy patient to spread the word, and they'll all come knocking on your door asking for them. So just a little bit of a summary for some points here. If you just take these 6 points and move them forward tomorrow in your practice, I think you'll be more successful and grow that multifocal business. And at this point, I should probably hand it over and invite you to bring any questions to me. So thank you very much for your attention. And let's see if we've got any questions in our chat. So I have one. Somebody's asked, when I'm doing a contact lens fitting, should I use a trial frame with loose lenses in it, or should I use a phoropter when I'm checking them for an over-refraction? That's a great question. I didn't actually cover that in my list of tips, but I am a great believer that if they've got contact lenses on their eyes, you should be using either loose lenses or lenses popped into a trial frame. And this will lend itself to allowing you to get that patient to be walking around. Maybe they felt their distance vision wasn't quite good, so you're going to put a little bit of an over refraction in that trial frame and get them to look out the window if you've got a window. See if that makes a difference, or get them to bring the phone out if it's a near vision problem that you're trying to fix. But a loose lens will allow all of those and allow them to operate in a more natural environment. I know we talk about proximal accommodation, and the younger presbyopes will still have some accommodation to deal with that. But I just think getting a full lens, a free lens, will allow you to do those checks of looking far away, looking at a phone, looking at a book, something like that. So yeah, I would not use a phoropter for sure. Thank you for the question. Do you have any recommendations on how long a patient should try to wear contact lenses before they give up and don't want to wear them? Well, we can't force them to keep going, but I think this is an issue of communication. So giving the patient an understanding that you have a series of steps that you'd like to walk through to try and optimize for them. Now, if it's a visual issue, then I would always suggest that if you're going to change the prescription, you're going to let them experience that new prescription for at least a week, maybe a little bit longer, depending on their issue. So not a quick turnaround on that. If it's a comfort issue, particularly if it's a lid concern, then you may want to be allowing those management strategies to take place. Now, they're not always a super quick fix. So I wouldn't rush to say, oh, well, you're allowed 2 lenses and that's enough, because it really is going to depend on that patient and what the problem is that they're getting. They're not going to work for everybody. So at some point, you may come to a situation where you say, well, you know what? I can't really do anything different. And maybe that endpoint is that you give up altogether, or maybe that endpoint is, how about you just have them to wear now and again when you want to? So I think most contact lens wearers like to hang on to them, even for that social wear. I put mine in tonight. I didn't wear them through the day, but I put them in for this presentation. It wouldn't look good if I was sitting here in spectacles either. Another question that's come in. How do multifocals work at night? I think that question is. How do multifocal night contact lenses work? Certainly anything that has a slight compromise on the vision, and that would be monovision or multifocals, those compromises can be exaggerated in low light. And that's why those examples I gave of somebody who does a lot of nighttime driving or someone who goes to the theater may appreciate having that specific distance vision. So, that's always an option. And it's something that's so easy now that we've got a daily disposable option. So you can give them multifocals for the majority of their time, and then they pack a pair of single vision distance in their wallet, carry them around with them for when they need to use them in those situations. So flexibility, doesn't have to be full-time wear. They're all keys to being successful and keeping your patients in the driving seat and decision making and being part of their journey. I'm getting a bit of a wrap-up signal here, so I would just like to thank everybody for joining me. I hope it's been interesting and informative, and yeah, enjoy the rest of the sessions. Thank you very much for your time.